All right. Hi, everybody. Dr. Arafich here, Vet Triage. I'm in the Soho Lounge in JFK on my way to London, so that's why the airport background. But let's get into it. We're still going through this issue of JAVMA. This is the May 15, 2018 issue. We're talking about this paper, Chylous ascites associated with abdominal trauma and intestinal resection-anastomosis in a pet ferret. And this comes out of France and Belgium and Montreal. Case description: this is a 10-week-old ferret that was referred for exploratory laparotomy because of pneumoperitoneum, possible septic peritonitis after being bitten by the owner's dog. So exploratory means that the veterinarian is going to explore, they're going to investigate blindly, pretty much. Laparotomy is synonymous with coeliotomy, which is a generic term to mean entering the abdominal cavity. Pneumoperitoneum means that there's air built up in the abdominal cavity outside of where it's supposed to be, like stomach and intestines. Septic peritonitis is bacterial, usually bacterial, but could be any infectious organism that causes inflammation of the peritoneum, which is the lining of the abdominal cavity. Clinical findings: they found a large laceration of the duodenum. They found tears in the jejunal mesentery, tears in the abdominal wall, and then 2 days after surgery, a chylous ascites formed. Postoperative care included supportive treatment, analgesia, antibiotics. They placed an abdominal drain. They placed an E-tube, also known as an esophagostomy tube, to help with feedings. And then when the chylous fluid buildup began, they started octreotide. The chylo-abdomen resolved after 8 days of hospitalization and medical treatment. Okay, let's go into the introduction here. The ferret had lethargy, was recumbent, had a borderline high body temperature, abdominal distension, ecchymosis. Ecchymosis is um, uh, pinpoint or spotting of bruising over the skin area, and what that tells you is usually a problem with with primary hemostasis, which is the platelet plug. There's only three things that can cause ecchymosis and petechia in animals. Either you have low platelets or thrombocytopenia, abnormal platelet function or thrombocytopathia, or von Willebrand's disease. Abdominal palpation elicited pain. They started IV fluid therapy, analgesia with hydromorphone. Radiographs of the abdomen showed a loss of serosal detail, free air in the abdomen, loss of the integrity of the right abdominal wall with herniation of small intestines, and contusions of the right middle lung lobe. Contrast radiography confirmed that there was a perforation of intestinal loop. When they referred the ferret, he became stuporous. He was tachypnic, tachycardic, laterally recumbent, febrile. His mucous membranes were pale. He lacked a capillary refill time, abdominal distension, abdominal pain. The blood pressure was low. He had a mild anemia. He had a high BUN, which is blood urea nitrogen. He had low protein. And then the diagnosis was suspected cause of all this was septic peritonitis and gastrointestinal bleeding secondary to abdominal trauma. He also had hyponatremia, which is thought to be due to third space fluid accumulation. They did an ultrasound, which found hyperechoic peritoneal effusion and small intestines that were distended with fluid with no peristalsis. They started treating with enrofloxacin, also known as Baytril, lactated Ringer solution, and the heart rate decreased. The capillary refill time was improved, but still not normal. They premedicated the ferret in preparation for surgery with midazolam, fentanyl. They pre-oxygenated. They induced with ketamine, maintained with isoflurane, and they had a fentanyl CRI as well as lidocaine CRI to help with pain in surgery. Because of the blood pressure issues, they started phenylephrine, and they were bolusing hydroxyethyl starch, which is a colloid, as well as lactated Ringer solution. So here's a picture from surgery. The top picture, A, they're trying to show the effusion that was present. You can see all the gross green stuff on the organs. And then B shows the hole. That's where the arrow is, the tear in the duodenum. And then this is the arrow is pointing to a tear in the abdominal wall, and the asterisk is the kidney. The kidney's fine. They're just showing for purposes of the picture. So they found a large laceration in the descending duodenum. They found small mesenteric tears. They found that a large portion of jejunum was dilated and paralyzed, and they had the perforations of the abdominal wall. They performed a duodenal resection-anastomosis, and they closed the perforations in the mesentery. They placed a Jackson-Pratt surgical drain, also known as a JP drain. This has automatic suction, so they can remove fluid after surgery and make sure there's no bacterial infection, see if the fluid's going up or down. JP drains are great. And you want to place JP drains in cases where you anticipate abdominal effusion being a problem after surgery. So certainly a septic peritonitis warrants it. Postoperative care includes crystalloids, colloid, enrofloxacin, cefazolin. They continue with phenylephrine, and then eventually stopped that and began norepinephrine as a vasopressor instead. The hypotension persisted. They had him on phenylCRI, ketamine, and then he developed hypoglycemia. They started dextrose. They were removing a substantial amount of fluid from the Jackson-Pratt drain. It described as being serosanguinous. The rate was 6.7 mils per kg per hour. After the first day, he persistently was hypotensive, stuporous, tachycardic. He wasn't producing urine or feces. He had repeat blood work done that showed severe leukopenia with neutropenia, left ship, toxic changes, high alkaline phosphatase activity. All of this consistent with sepsis-induced cholestasis and severe hypoalbuminemia with hypoglobulinemia due to loss in the abdominal inflammatory effusion. High creatinine was found, suggesting preurinal azotemia because of a normal urine-specific gravity. Fluid therapy was changed from LRS, or lactated vinegar solution, to an alkalizing solution with slightly higher sodium to make up for the loss of sodium. They then placed a 10 French esophagostomy tube and a urinary catheter. They started metoclopramide to help with intestinal motility. They started morapitant to help with nausea, famotidine as a gastritis protection, and then they added metronidazole as another antibiotic. Day 2, they started feeding through the E-tube. Blood pressure improved. Day 3 continued to improve. They started omeprazole and replaced that. They replaced the famotidine, and then they stopped the morapitant for nausea. The E-tube volume fed was increased to 50% of the patient's requirements. The repeat blood work showed mild anemia that was thought to be either hemodilution, blood sampling, or inflammation. They found a left shift and toxic changes in neutrophils in the blood work, so improvements there still. Low albumin, low globulins persists, and that was thought to be due to loss via the digestive tract and inflammatory process associated with sepsis. Abdominal fluid production remained high at 6 mils per kg per hour, but improved. And the fluid started to have a cloudy white appearance to it. And so this is the cloudy white fluid there. You can see that they were getting from the drain. So on day 4, abdominal fluid production had increased to 8.2 mils per kg per hour, and the fluid had a milky appearance. It was diagnosed as Chylous effusion with non-septic neutrophilic inflammation and had triglyceride concentration that was consistent with Chylous effusion. They found lymphocytes at 43%, non-degenerative neutrophils at 38%, and monocytes 19%. No microorganisms. Chylous effusion was diagnosed, and the enteral feedings were then modified to a diet for obligate carnivores such as ferrets and cats. On day 5, the patient still required norepinephrine to maintain blood pressure. E-tube is now 2/3 of the requirements with feedings. Normal puring bowel movements. Bacteria culture from the abdomen found Streptococcus species, and they started beta-lactams as a result. So they started cefazolin. Then days 6 and 7, the abdominal fluid even higher, 12.7 mils per kg per hour. So they added octreotide, which is a somatostatin analog, and that's been used successfully with chylothorax and Chylous ascites in the literature. On day 8, the ferret started eating on his own. The abdominal drain was removed, and the entrance site of the drain closed. They decided to place a second abdominal drain, not an additional one, but a subsequent one. because of the fluid production being a problem, and then eventually the Jackson Pratt drain was obstructed. So the fluid production decreased dramatically to 3.8 mils per kg per hour within 36 hours after adding octreotide. Days 9 to 11, the ferret continued to improve. E-tube was removed, fluid production decreased. On day 11, it was 0.2 mils per kg per hour. The drain was removed. Blood work showed low albumin and polychromasia and toxic changes in neutrophils. Patient was discharged 24 hours later with clavamox, which is an antibiotic, and octreotide. 2 months after surgery, he'd been doing well. 30 months after, no complications. So now the discussion. This is the first documented case of abdominal chylous effusion secondary to abdominal trauma and surgical intervention in a ferret. It's been reported in dogs, cats, horses, bovids, meerkats, red pandas, cheetah, hedgehog, and hamster. This is due to a disruption of lymphatic network. In humans, it can be from congenital issues, trauma, obstruction, or external compression of lymphatics, infection, hepatic cirrhosis, or inflammatory diseases. It has been diagnosed in a calf with congenital issues, and in a foal, it's also been diagnosed with in cancer in cats, and the only other report of a ferret had cancer. Steatitis secondary to vitamin E deficiency in a cat. Steatitis is inflammation of the fat. Feline infectious peritonitis, or FIP. Pancreatitis in a dog and in meerkats, and then hepatic cirrhosis. Chylous ascites was described in a horse following a nephrectomy, which is removal of the kidney. In human medicine, postoperative chylous ascites is a rare complication from disruption of the major retroperitoneal lymphatics. Chylous effusion appears for a few days or even a month after surgery is performed. It's highly unlikely in this case that it was iatrogenic, meaning the fault of the surgeon. Definitive cause of the chylous effusion was not identified. However, blunt trauma was suspected. Blunt abdominal trauma as a cause of chylous ascites is better described in human medicine, especially in pediatrics. It accounts for 19% of such cases in literature reviews in these kids. Blunt abdominal trauma is believed to cause chyloabdomen as a result of hyperextension and hyperflexion of lymphatic vessels, leading to rupture of those vessels and lymphatic leakage. Conservative medical management resolves chyloabdomen after 48 hours. In this report, in human medicine, medical management is the initial therapeutic approach, with nutritional support being important components to maintain nutrition status and influence chyle formation and flow through the thoracic duct. Total parental nutrition, also known as TPN, is generally advocated, although a provision of a high protein, low fat diet with medium chain triglycerides is an alternative. Medium chain triglycerides are absorbed directly by the intestinal cells and transported as glycerol and free fatty acids directly to the liver via the portal vein. Unlike long chain triglycerides, which are converted to monoglycerides and free fatty acids and then transported as chylomicrons to the intestinal lymphatics. Such diets reduce the production and flow of chyle in humans, but don't seem to influence chyle production and flow in dogs. In the ferret described here, TPN was not recommended because of the need to maintain mucosal integrity of the small intestine, encourage healing by reversal of mucosal atrophy induced by starvation, and increase anastomotic collagen deposition and strength. Finally, octreotide has broad-ranging effects on the body, and its use in chylous effusion stems from its effects on the gastrointestinal system. The exact mechanism is unknown. However, the drugs have multifactorial effects on the GI system, and reduction in splanchnic blood flow are thought to reduce the thoracic duct circulation and triglyceride content of the chyle. Octreotide has been shown in animals to shorten the time of chylous fistula formation and cessation of chylous drainage, and the use of octreotide is often recommended in humans as an adjunctive treatment. In humans, you expect chylous fistula output to decrease after 24 to 72 hours of treatment. So yeah, most of us are familiar with chylothorax as being a buildup of chylous effusion, not the abdomen. And so, yeah, I had one dachshund case where he had hemilaminectomy, he had spine surgery, and he developed a chylothorax the day after surgery. We didn't figure out why, and we thought maybe it was due to trauma because the dachshund fell down the stairs. So I'm in agreement, at least with that one case in my experience, that blood trauma was probably the cause. Okay, thanks everybody for joining. I'm going to try to be on again tomorrow. We'll see. It's been a long day, and it'll be a long night. But take care.